Hi, my name is Saad Usmani. I'm the Chief of Plasma Cell Disorders Division at the Levine Cancer Institute, and I'm here at the International Myeloma Workshop in Boston with my colleagues Ajai Chari from Mount Sinai and Niels van der Donk from Amsterdam. And we are going to be talking about immunotherapies in myeloma. There's been a lot of data that's been discussed. It's been a very busy meeting for us. I'm going to go to Ajay first and get his opinion on his wonderful monoclonal antibodies overview talk that he gave, and just give us a scoop on what you discussed.
Sure. I think first is we talked about antibodies, but the antibodies are only possible for myeloma. We didn't get an antibody till 2015, almost 30 years after they were developed. So we have currently approved the two antibodies for daratumumab for CD38 and ELO, the CS1. And I think it's nice that we have newly diagnosed indications in combination with Lendex and VMP for DARA, in early relapse with DARA, both with Len and bortezomib, and ELO with Len, and most recently ELO with POM as well in the more heavily treated, and also DARA-POM. So we have this kind of distribution of approvals, but I think there's a lot of interesting developments. In particular, DARA sub-Q will make this a lot more convenient for patients. And we've also heard a little bit about the novel CD38s, isatuximab, TACO-79, MOR202. So I think those are some of the exciting developments in monoclonal antibodies.
All right, and then what about CS1 as a target, Niels? What are your thoughts around that?
Well, we have now elotuzumab targeting CS1 or SLAMF7, and I think the combination with POMDEX, ELO-POMDEX, with a median PFS of 10 months is an interesting combination. Because ELO in combination with Lendex, I think, is not widely used in Europe, and probably also not in the US, because DARA-RD has shown superior results in that setting. So I think after that, ELO-PD may have some value, although there are also many other POM-based combinations in that setting.
Right, and again, in the US, I think at our center, we've been using ELO-POMDEX post-DARA exposure, and we are encouraged by the results that we're seeing in patients, which is surprising. That's not something we were seeing with ELO-Lendex, but I think that there's something more to do with the ELO-POM combination where the NK cell function is perhaps enhanced. What do you think, Ajay?
I think the real strength of ELO-POMDEX is really the toxicity profile, right? It's very uncommon that you add a third drug and you actually see less neutropenia, which is, I think, in part due to the disease control. So that's really encouraging that you're getting this PFS improvement. But I do think we need a little bit more formal data, because there's very few patients, and in the published studies, there's been no really DARA-treated patients. Right. And so I think we need a little bit more prospective data, because somebody who's progressing on a DARA-based regimen with clinical relapse like CRAB symptoms may not be put on an ELO-POM. Right. So I think there's a little bit of a selection bias. And right. I do think it'd be nice to also formally study the NK cell recovery, right? Because we know that DARA depletes your NK cell, which is required for ELO's activity. And so do we need a little bit of a washout, or can you go straight over it? So those are some unanswered questions, but I think ELO allows, the POM, ELO-POM label allows ELO to be used beyond the LEN, which is before it was a use it or lose it situation. Now you can still use ELO in a later line. Right,
and this gets to the mechanisms of what's happening after post anti-CD38 monoclonal antibody exposure to our patients. Are we changing the natural history of the disease in some ways? Because there were some myeloma physicians who actually pointed out that maybe they're seeing a higher incidence of extramedullary disease and more aggressive clones come out at the time of relapse. And Niels, this is down your alley. You've worked on anti-CD38 monoclonal antibody resistance mechanisms, so maybe you can make a few comments around that.
Well, if you talk about anti-CD38 antibody resistance, I think there are multiple aspects, and in fact, we do not know yet the whole picture. But I think we see increased levels of complement inhibitors on the tumor cell surface. We see some changes in the immune system, maybe a shift towards a more suppressive microenvironment at the time of relapse. And of course, the target is already very early on reduced by 90%. My experience, in fact, is that DARA failures can also be very well rescued, because I think these patients are often resensitized to IMiDs. So in my experience, giving an IMiD drug after DARA failure often works perfectly well, even though the patient has already been exposed to pomalidomide or another IMiD drug. In my clinical experience, we see more extramedullary disease in patients that have received more prior lines of therapy. But to my idea is that this is not a effect of DARA. I think that's just because patients have multiple lines and then you see extramedullary disease popping up.
Yeah, so after the DARA approval came, that was our experience, and we ended up publishing it, and Emery actually presented it at one of the ASH meetings before publishing it as well, that DARA exposed or refractory patients or POM exposed or refractory patients, when they get the combo, you still get over 30% response rates, and patients stay on it for several months. So there is, you're right, validity to the enhancement of activity that you get with the IMiDs. Ajay, what do you think?
I think there's two principles when we practice evidence-based medicine. If you are looking for the outcomes of randomized studies, we already have two examples, both with ELO-RD, but more importantly with ASPIRE, and actually now also ENDEAVOR, where the PFS benefits translated into OS benefits. Right. So because DARA is more recently approved, we don't have the left follow-up, so that'll be very important to answer this question. But historically, the magnitude of PFS benefit that we're seeing with DARA is hard to believe will not translate into OS, with, of course, the caveat always that OS is confounded by access to drugs, right? So if your salvage therapy is suboptimal, you will never be able to really answer that question. But I think the second thing is also it's important to remember that we think that, there's concept of saving good drugs for later versus using it earlier. I think that's a little bit of a fallacy, because if you start with 1,000 patients that newly diagnosed, not all of them will make it to the third relapse, and you're going to lose patients along the way. And so it's a little presumptuous to think that you can save something for later when patients don't make it, because every step of the way you're losing. So
I agree. So Rafa Fonseca and I had this poster at ASH about the attrition rates with in the era of novel therapies, and you're right, we're losing almost a third of patients with each line of treatment. Right. And then again, who wants to hold back Michael Jordan from the NBA Finals? Oh, we'll save him up for the last minute of the game, right?
Exactly.
So it's that analogy that Joe McHale usually makes. Within that session, Leifberg Segel actually brought up a very interesting question, and I was hoping that it would be you, Niels, because you guys have generated this data, that maybe adding low-dose cyclo or ATRA can actually resensitize patients to monoclonal antibodies.
Yeah, so we are currently performing a clinical trial to see whether we can upregulate CD38 and downregulate complement inhibitors with all transfer ethanoic acids. So we are analyzing this trial, and I hope to present soon the clinical data of that. And we also have, in Europe we still use a lot of cyclophosphamide, and we have published some studies that adding cyclophosphamide to lenalidomide, and in America, BAS has shown that adding cyclophosphamide to pomalidomide are really good and synergistic, fully oral combinations, and also much cheaper, of course, than combining an antibody with pomalidomide. So we like to boost activity of IMiDs antibodies with low-dose cyclo.
Yeah, and cyclo, there is preclinical data that shows that CD38 expression goes up, as well as there might be some polarization of CD38.
Yeah, increased expression of Fc receptors on the macrophages. That's work from Michael O'Dwyer.
But I really like what Niels said, that it's not, I think it isn't just the CD38 expression, because we talk a lot about increasing antigen exposure, but as you mentioned, when you treat with DARA, CD38 expression is lost quite early, but you still see deepening of responses. So it can't be just what's expressed on the cell, and I think it's a lot more about the immune microenvironment, the complement.
It's that right side of that figure that we keep on top of.
Yeah, exactly.
Yeah, the immunomodulatory effects because of the reshaping of the immune microenvironment.
Right.
By the elimination of immune suppressors.
Okay, I'm going to jump gears a little bit, because we have been hearing a lot about BCMA for the past 2 years, and now we have more clinical data than preclinical data. So what are your thoughts about BCMA as a target in myeloma?
I think it's a very interesting target, because it's highly specifically expressed on myeloma cells, on plasma cells, and maybe a small subset of more mature B cells, but there are not a lot of tumor on-target effects. So I think it's a perfect target. Also, the majority of myeloma cells express BCMA, and we have now a whole bunch of agents targeting BCMA. We have the ADCs, we have the bispecifics, the BiTEs, also CAR-Ts. So we really have to learn which patients benefit most from which type of agent.
So Ajay, what are your thoughts about bispecifics versus ADCs? As we gather data, are we going to be looking at safety versus efficacy in making those decisions? How to combine them with other partners? I mean, there are a lot of questions that are open, but I just wanted to get a sense from you what your thoughts are.
It seems like anything you throw at BCMA works lately. I think the question is really the risk-benefit profile of each agent, right? So the T-cell engaging drugs, and I call that because BiTE really is that really short molecule, and so we now have larger antibody structures that also are engaging T-cell. But the T-cell engaging drugs, they share the risk of cytokine release with the first few doses. They really, after that, it's pretty well tolerated, but they typically require more frequent administrations. The ADC is IV, 1 hour, no risk of CRS, every 3 weeks, so very convenient, very easily givable in the community, but significantly hampered by the ocular toxicity. And we know that's because of the conjugated, the poison, if you will, the payload is MMAF, which is known to cause ocular toxicity, in particular corneal damage. And I think the real question is going to be seeing the DREAM2 study, which will truly be the penta-refractory, triple-class refractory, because up till now, for both drugs, we've seen encouraging preliminary activity, but truly in the unmet need of triple-class refractory, we have very limited denominator so far. And so I think in that population, the question will be, what is the response rate? How much dose holds are required? How much dose modifications are required? And also, because of the significant impact of ocular issues, what is the quality of life for patients? Because I think if you're going to have different agents and they're going to give comparable efficacy, the patient experience could really sway you in picking one versus the other.
And I guess, when we get to combining these with other mechanisms of actions, eventually, you'll have to keep that safety profile in mind too. Yeah. It may be very different. I mean, it will be different for the bispecifics, where you would think that, the IMiDs would be better suited. But with the ocular toxicities, one of the things that we talked about yesterday was the proteasome inhibitors. We don't recognize this, as much as we would, but bortezomib does come with some ocular toxicities. Patients with blepharitis, or dry eyes. And if we were to combine an ADC, targeting BCMA with a PI, what are the results? We see this with carfilzomib as well, but not as pronounced as we do with bortezomib.
No, I agree, and I think both the ADC and the BiTEs have high single-agent activity, 60%, 70%. So I think both agents are highly promising, and we still have to learn how to best treat our patients with these drugs, and the best strategy of how to incorporate these drugs in our treatment regimens, maybe as part of consolidation or in certain combinations.
And of course, the other question is sequencing, right? Because we now have, if you have these two products, and of course CAR-T, which is also targeting BCMA, can you go from one to the other? And how do you, is there time required? And especially with the CAR-T, where you give the flu-cy conditioning, will patients be salvageable with a bispecific after that when they don't have T cells remaining? So I think a lot of unanswered questions, and right now a lot of these studies are precluding patients with prior anti-BCMA therapies from current BCMA.
There is some anecdotal data that ADC works after CAR and vice versa, but Janssen is now also going to enroll a separate cohort of patients that are going to be treated with a CAR T cell targeting BCMA, but all these patients must have had a prior BCMA targeting agent to answer this important question.
And one interesting thing, I know, CAR-T is not this topic that we are going to be focusing on, but the post-CAR-T patients, there are anecdotal experiences that myeloma investigators were sharing that previously, drugs they've received previously or monoclonals they've received previously, post-CAR-T relapses, patients are getting resensitized to those. So I think this may be that clonal tiding rather than clonal evolution aspect of things. One particular target that we are just going to touch upon, and we're just learning about this, GPRC5D. We know that it's also a lucrative target in myeloma. And Ajay, do you want to share some of what's in the pipeline right now and data to look forward to?
So unlike the multitude of agents targeting BCMA, there's very few targeting GPRC5D. So this is a G-coupled protein receptor, which is expressed on myeloma preferentially. So like BCMA, good target, because we don't see a lot of non-myeloma cell expression. So lends itself to targeted therapies. And the two approaches are the bispecific, which Janssen is sponsoring, but also there's work doing CAR-Ts targeting the same. The antibodies still in phase 1 testing, so we'll have to see the data. And of course, CAR-Ts are still even further behind. But I think this will be a great opportunity because if everything is targeting BCMA and people progress off that, at least you have a new target to try.
And also maybe in the further future, you can combine both targets at the same time to prevent the development of antigen escape variants.
Yeah, I think
but that's even further in the future.
Exactly. That's maybe the IMW meeting in 2027, and that we'll be talking about that. Hopefully, we're around for that. The last topic I want to touch base on you about was we've talked about myeloma microenvironment. How do we influence and immune modulate? We've talked about direct cell kill of myeloma cells using monoclonal antibodies with ADCs. But what about immune signaling? We were very enthusiastic after having seen the phase 1/2 data with PD-1, PD-L1 inhibition along with immunomodulatory drugs, so Pembro, Lendex, and Pembro Pomdex 3.5, 4 years ago. But the phase 3 trials were a little disappointing. So I'm just wondering what kind of lessons do you think we've learned? Is there still hope for looking at checkpoint inhibition? Was PD-1, PD-L1 the right target in myeloma? Should we be looking at other things? Is checkpoint inhibition really a death story in myeloma, or there's more to it than meets the eye?
I think the questions are which checkpoints and which combinations, right? So it also is a good pause in drug development, right? Because the initial Lendex checkpoint looked very promising. PD-1 combinations looked very promising. Pembro Pomdex had an unprecedented PFS in phase 2 study of almost 15, 16 months. And it's only when we did the randomized study that you see that there was a toxicity associated with that. So I think it gives us pause that you see toxicities that you normally do not see with IMiDs, and it actually shows the potency of IMiDs as a drug, right, to actually accentuate the immunomodulatory effects and the interaction with the checkpoint causing increased autoimmune toxicity. So I think the question is, there's a lot of other targets that maybe, for example, there's a new CD46 that engages the macrophage that's also being targeted. So novel checkpoints may be a better strategy. And the question is also, should we do checkpoints with other agents other than IMiDs, given the additive toxicity?
Yeah. No, I agree. There are now multiple studies going on to evaluate PD-1 or PD-ligand 1 inhibitors with cell surface antigen targeting agents like DARA or elotuzumab. And maybe also PD-1 and PD-ligand 1 inhibitors may be beneficial in combination with CAR-Ts or even bispecifics. And other checkpoint inhibitors on T cells in myeloma patients like LAG-3, TIM-3, TIGIT may also be good candidates to further explore. But I think we need more data before we can definitely say something about the role of these agents.
Okay, well, I would like to thank both you, Niels, and Ajay for a wonderful discussion on this topic. Thank you for joining us in this educational activity. Goodbye.